Yeah, I invite Dr. Shubhrata Devnath for a topic of robotic surgery in gynecology to the dais and illuminate us with his lecture. All these topics, the next before lunch, pre-lunch sessions are going to be very interesting. So I found some of our esteemed doctors and members sleeping or talking in the back. I don't know how much appropriate it is for me to comment, but I was sitting on the back and I found them. So please be interested, please be careful to listen to all these interesting topics pre-lunch session. And I'm sure you will learn so many things and you will definitely deliver to your patients much better care. Thank you.
Good morning to all. I will speak few words regarding the robotic surgery. What is the advantage of the robotic surgery over the laparoscopy and what are the recommendations of the robotic surgery? First, what is robotic surgery? Robotic surgery is done by the surgeon and not by the robot. It is basically a surgical system that connects between the surgeon and the patient. The most recent advantage in the surgical system is the robotic surgery. There are different robotic systems in the market available, but most commonly used is the Da Vinci surgical system. Da Vinci surgical system, I want few words regarding the Da Vinci surgical system that is most commonly used in the different institutions. And I will show one small video of the robotic radical hysterectomy in case of the uterine cancer. Da Vinci surgical system has the three parts. There is the patient cart, is the patient side manipulator, and the surgeon console where the surgeon will sit and operate, will see in the 3D vision and move the robotic arms using the joysticks. And the vision cart where the assistant surgeon will see. This is the most advanced robotic system, that is the Da Vinci XI system, and another system is available in the Da Vinci surgical system, that is the X. Basic difference is this is the vision cart, this is the surgeon console where will sit and operate, and basic difference between the XI and the X is the robotic arms. You can see in the XI system, this arms hangs from the ceiling. So it is easier to operate both upper quadrant surgery, abdominal, and the lower pelvis surgery using the same position of the patient. In difference, the X is this arms hang from the side wall. So if I am doing the lower abdominal surgery, same setting I have to do the upper abdominal surgery, I have to move this patient. In case of the XI system, there is a press button is there behind this bar. So if we press the press button, robot will move automatically towards the upper abdomen. And this is the surgeon console where sit and operate. We'll see in the 3D vision. This is the joysticks, and these are the foot pedals like the other laparoscopic settings. And this is the vision cart where the assistant surgeon or OT technician will see the operate. Rest of the pneumoperitoneum setting like all other the laparoscopic surgery. These are the robotic instruments. Robotic advantage of the robotic instruments is that they would have this endo wrist. Having this endo wrist, they can move at any direction more than 360 degree. So in case of the oncological surgery, the oncological clearance will be better with this robot. Now, what are the indications of the robotic surgery? Any benign gynecological condition like deep-seated endometriosis, fibroid surgery, or any other ovarian cystectomy can be done by the robot. In case of the oncology, radical hysterectomy in case of the endometrial cancer, robotic completion surgery in case of the incomplete stage endometrial cancer, pelvic and periaortic lymph node dissection, robotic cytoreductive surgery in case of the C ovary, robotic veil. In case of veil means video endoscopic inguinal lymph node dissection. Now, what are the advantages of the robotic surgery over the laparoscopy? The laparoscopic surgery is well known to all, but robotic surgery is relatively new. But why to choose robotic surgery? What are the advantages of the robotic surgery over the laparoscopy? In robotic surgery, there is the real 3D. We can see the 3D vision. And in laparoscopy also, someone said that 3D laparoscopy is available. But in laparoscopic surgery, 3D is the converted 3D. It is not the real 3D. And the learning curve for the surgeon in the robotic surgery is relatively less. Robot has the multiple joint. Endo wrist has the multiple joints. The advantage of the multiple joints, it can, in case of oncological surgery, lymph node clearance or any tissue clearance is better. No one space limitation. And one advantage of the robot is the tremor filtration. If 70 years of surgery is doing the any laparoscopic surgery once or open surgery, he might have some tremor. But robot has an integrated software system that will filter the tremor and the real movement. If surgeon is having the tremor and he is operating sitting in the console and the joystick movement, some tremor is there, tremor will be filtered by the robot and the real movement will be transmitted in the patient card only. And there is no fatigability for the assistant surgeon, no fulcrum effect. In laparoscopic surgery, laparoscopic instruments are the rigid instruments. So they are using abdominal wall as a fulcrum. So abdominal wall injury is there. In case of the robot, there is no fulcrum effect. So the injury to the rectus muscle is very less. So there will be less pain. This is the one patient that I have operated CA endometrium. So I will show this video. She is a 65 years lady. Came to me with a complaint of the post-menopausal bleeding for the 10 to 15 days. Ultrasonography shows the increased endometrial thickness. I did the hysteroscopic biopsy. It shows the endometrial carcinoma grade 1. And metastatic workup shows that there is no metastasis. This is the pictures of the docking of the robot video. This is the optical port where they place the camera. This camera position is 20 to 21 centimeter above the symphysis pubis. This rest, all of the ports are the 8 millimeter in size and 8 centimeter apart. Each distance one port to another port is 8 centimeter. This is the assistant port of the 12 millimeter. In the right hand there is the monopolar camera, and the left hand there is the bipolar. This is the grasper. And the one additional advantage is the robot that if I put this camera here, I can shift my any of the button of any of the camera. I can place the monopolar here, I can place the bipolar here, I can place the camera here. This is the advantage. If I want to change, I have the foot in my console, there is a foot one button, the shift button is there. I can change any of these at any position. And this is the case history. I will show this video. This is the robotic radical where I will sit and operate. This is the surgeon console. This is the position where I will sit and operate. This is the same patient with the docking after docking. See, this is the lymph node clearance. This is the left sided pelvic lymph node dissection. This is the monopolar. And first I have opened this broad ligament area. You can see here the external iliac vessels. To start, I have ligated the uterine artery. This is the internal iliac artery. That is the origin of the uterine artery. I have ligated the uterine artery at the origin. In case of the CA endometrium, one can do the simple hysterectomy also. But I always do the type 2 radical hysterectomy. This is the internal iliac artery, and the origin of the I have ligated the uterine artery at the origin. That is the pelvic lymph nodal dissection step. This is the cranial end of the pelvic lymph nodal dissection. Here we can see these all are the fatty tissue embedded in the lymph nodes. This is the external iliac artery. Lower behind the external iliac artery there is blue structure is there. You will see clearly after few seconds. This is the external iliac vein. This white structure is the obturator nerve. When you will see the obturator nerve, this is the posterior boundary of the pelvic lymph node dissection. This blue structure is the external iliac vein. See all these cutting and the vessel sealing all are done with this monopolar and the bipolar. This is the bipolar instruments, this is the monopolar instrument. All the movements I have done in this sitting in the surgeon console, all are being transmitted to the patient card. See, you can see clearly all the structures, and the bleeding is very less. If we do the radical hysterectomy in open surgery, the bleeding is much more. You can see that after the completion of the surgery, entire surgery, the blood loss is almost 100 ml only. This is clearly the external iliac artery, external iliac vein, and this is the bifurcation of the common iliac artery. So I will dissect cranially up to the bifurcation of the common iliac artery. This is the cranial boundary of the pelvic lymph node dissection. This is the psoas major muscle. This white small thin white structure is the genitofemoral nerve. This is the left genitofemoral nerve. And this is the cranial boundary. Up to this much I have to do for the left pelvic lymph node dissection. Same way I have to do the right side also. See, this was clear. This clear pelvic lymph nodal dissection or any oncological tissue clearance is only possible in the robot. This is not possible in the laparoscopic surgery also. This so much clearance is not possible in the laparoscopy. So this oncological clearance, if it is done properly, then the patient's survival will be better. No tissue left behind. This is the obturator fossa. This is the external. This is obturator nerve, and here you can see this is the left ureter. This is on the left ureter. The white structure is the left ureter. Ureter is the medial boundary of the pelvic lymph node dissection. You can see this obturator fossa clearly. This is the ligation of the infundibulopelvic ligament. Infundibulopelvic ligament, I always put one clip, but someone can ligate also with this bipolar, coagulate and cut. But in case of the uterine cancer, this vascularity always increase. So I always put one hemlock. These are the joystick movement that has been transmitted to this patient card. That is the POD, that is the pouch of Douglas. Here is the rectum. This is the ligation of the round ligament. Now here is the bladder. That is the uterovesical fold of peritoneum. This one is the bladder. That is the uterovesical fold of peritoneum. Here I have ligated already the uterine artery. This is the end of the uterine artery. So I will pull just the uterine artery radially. This automatically the lower tissue and the ureter will goes down. So some chances of the ureter injury in case of the radical hysterectomy, if we follow this step, there will be less. See, this is the joystick movements that are transmitting to this patient card. This is the one display where the adjustment button is there. We can adjust this button. And these are the vault and all specimens retrieved to vaginally. In case of the CA endometrium, high-grade symptomatum, we have to do the retroperitoneal lymph node dissection. Usually, and this was the grade 1 endometrial cancer. In case of the low-grade endometrial cancer, retroperitoneal lymph node dissection is not required. In case of the high-grade endometrial cancer or uterine cancer, usually they metastasize to the left paraortic space. This is on the left paraortic space. In case of grade 3 endometrial carcinoma or serous carcinoma or any high-grade tumor, I have to do this retroperitoneal lymph node. These are the retroperitoneal space. It is the aorta. These are the left. Behind this bipolar, there is a left ureter is there. In between this space is the left paraortic space. This is the enlarged lymph node. See, amount of the bleeding is very less compared to the other open surgery or any other mode of the surgery. Here is this one is the aorta. This is the enlarged lymph nodal chunks, but ultimately final histopath comes out to be negative. In case of the CA endometrium, now the surgical staging system is there. There is no role for the, till today there is no role for the radiological staging system. After surgery, you will send all this tissue to the histopathology department. They will give the report which one is positive and which one is negative. After that, we will stage the disease, and depending upon the stage of the disease, adjuvant therapy usually decided. In case of if this tissue comes to now the 2023 guidelines, endometrial cancer staging has been changed. And that at this staging system they have mentioned the retroperitoneal lymph node sampling is mandatory. This you can see clearly, this is the aorta. This white structure is the aorta. If retroperitoneal lymph nodes comes out to positive, that becomes 3C2. If the pelvic lymph node becomes positive, that is the 3C1. Depending upon the stage, patient required adjuvant therapy. This is the vault. So all specimen retrieved from vagina. The advantage of the robot, you can see this after this extensive surgery. I usually admit the patient in the evening and do surgery the next day morning, and the evening onwards I allow patient to take the food, and next day morning by 9 AM she will take normal food and discharge ohm. There is very less pain and the less amount of blood transfusion usually not required in case of the robotic surgery. If I do the open surgery, staging surgery in case of the CA and rheumatoid patient will require so at least 4 to 5 days hospital stay. And oncological clearance, lymph nodal clearance is much more better in case of the robotic surgery compared to the open surgery. Thank you.
Dr. Shubhoto Devnath is requested to come down to the selfie zone, and Dr. P.L. Binani, ex-secretary and president of Family Physician Association, to honor him with a memento. Dr. Shubhoto Devnath, please come down to the selfie zone. May I have the lights of the selfie zone, please, audio visual people. Pardon me for my voice has cracked sometimes. A loud round of applause for the speaker. May I request Dr. Agarwal to call the next speaker of the next session.
Yeah, I am requesting Dr. Arindam Mukherjee for an interesting session in update in interventional pulmonology, a relatively new subject.
Good morning, everybody. Today we are going to discuss on an interesting new development in the subject of pulmonology. It is interventional pulmonology. It's a new subject altogether. So interventional pulmonology has stood the test of time, and it is now being performed over the last 3 centuries. Because Gustav Kaelian, the first person, a German otolaryngologist, to perform his first rigid bronchoscopy in 1897. Then it went overseas to America by Chevalier Jackson, and then the yesterday's wonder in mid-20th century become all the interest has been taken out by this Shichiro Ikeda when he has discovered this flexible bronchoscope. So this is the brief history of the 3 landmark discoveries in intervention pulmonology. But now we have come through a long way, and now we are coming to the diagnostic IP. So the real development in the diagnostic IP is the real-time guidance. We know the bronchoscope has a limitation due to its size as well as its diameter. Bronchoscope cannot go all the way to the periphery of the lung. So now it has a guided bronchoscopy. Guided means when the bronchoscopy is being done, it is being guided by some external instrument like a fluoroscope. And I will show you some of the instrument like this. So this is the picture of a cone beam CT scan. You can see the bronchoscope and the lesion was away from the bronchoscope. So when the tool has reached the bronchoscope, that has been taken up this radiology. And it can come to this precise placement of the tool. Whether it is at the center of the lesion, it is at the periphery of the lesion, it has passed the lesion, it is distal to the lesion, or it actually missed the lesion. You can actually understand on your CBCT screen by this image, and that is how you can determine whether you have actually reached the lesion, though you cannot visualize it on a bronchoscope. So this is a guided bronchoscopy. This is the newest development in IP. And another way of looking at it is a radial probivus, which is rather than an X-ray image, it's an ultrasound image. What we do? We put a ultrasound probe, which is much thinner than a bronchoscope, within the periphery of the lung. It takes the images, and on the quality of the image we decide whether we are in the lesion or not. Then we put a biopsy forceps through the same pad and take a biopsy from the intended site. So this also helped us to overcome the handicap of the bronchoscope, that we cannot reach the mid part or the distal part of the lungs. So what I think that presenting the cases, this newer development in a case-based approach will be more interesting. So I am going to discuss few of the cases on this diagnostic IP. Like the first case, he is Mr. T.A., a 67-year-old male presented with history of fever, but incidentally his CT showed fever and weight loss, and his CT showed mediastinal lymph node. Here you can see a big subcarinal lymph node. This subcarinal lymph node at this situation can be tubercular, can be sarcoidosis, or can be a lymphoma. So here we will show you how we will do a mediastinal cryobiopsy. So this is the carina, and this is the ultrasound image of the lymph node. So first we go to the carina and we put a needle under ultrasound within the lymph node to take sample. This is conventional EBUS. Here we can do only a FADC. But now we have this cryobiopsy for step. What is a cryo? This cryo I will show you, sir. After we have completed this needle FNAC, we again go in through our bronchoscope. We have put a cryo probe, and the hole that we have already made through our needle, we identify the hole, and through the hole we introduce the cryo probe. We will just see the cryo probe within the lesion. So this is the lesion or ultrasound imaging, and this is the cryo probe which has been introduced to that hole within the lesion. And when it is entered the lesion, it is well visualized in the ultrasound. So this is no more a needle, this is a biopsy now. You can thaw the tissue and take a large chunk of tissue and do all the required histopathology ISC examination. So it has actually make FNAC equivalent to biopsy. This is a new development, mediastinal cryoprobe biopsy. Let us come to another case. This is a CT thorax which is found in right upper lobe lung nodule. So this is the lung nodule you are seeing. If we go for a CT guided biopsy, you actually see there is a lung parenchyma within the nodule and the periphery. So there is a chance of pneumothorax. So this nodule is beyond the visualization of normal bronchoscope. But when we can introduce the radial probe with it, at this lesion we can see this concentric image. And this concentric image actually confirms that this is a neoplastic lesion. We can actually put a cryoprobe within this lesion and take a biopsy. Next case, this is Mr. PT, 48 years with no comorbidity, presented with 2 weeks history of fever and shortness of breath. This is the X-ray. We made a provisional diagnosis of viral pneumonia, but we come to a CT scan and this CT scan looks like that. There are multiple nodular lesions and the diagnosis was either infection or malignancy or vasculitis. And in this dilemma, at this point of dilemma, we decided to go for a biopsy. So here for the biopsy we use cryoprobe again and we take a cryobiopsy. Let us show you how to take a cryobiopsy. This is the balloon which we place within the lesion to decrease the chances of bleeding after the biopsy. You can see the balloon within the lesion. So this is the balloon which has completely put a tamponade in the endobronchial place, so no further bleeding occurs after taking the biopsy. So this makes the biopsy possible and much less complication from the procedure. After that it comes out to be NSIP, which means the disease is NSIP overlap and the patient completely cured with steroid. So come to next case. This is Mr. AJ, known case of CS stomach. He presented with us with progressive shortness of breath and this is the CT scan. We thought of PCP pneumonia and various kind of infections rather than malignancy. But as the patient didn't improve with all kind of antibiotics, anti-PCP therapy, we decided to go for a lung biopsy. So here surgical lung biopsy is out of question. He is very sick. So we do a lung cryobiopsy. So let us show how we do it. First we put a guide wire within the bronchial lumen. This is the guide wire. Over this guide wire, we put a balloon. This is the guide wire which is put first. Then over this guide wire, we put a Fogarty balloon. This balloon is used in CTVS surgeries previously. What this balloon do? This balloon can actually put a tamponade after you take the biopsy. This black thread, this is the cryoprobe. With this cryoprobe, we take a cryobiopsy for 4 to 5 seconds. And once the biopsy is taken, we take out the cryoprobe. And you can see a large chunk of tissue is coming out. But the bleeding has been arrested by this previously placed balloon, as the balloon has been inflated and almost completely occluded the lumen. So there was much bleeding, but it has not come out. It has not flooded the other bronchus and patient is safe. So this is how we done a biopsy, and this biopsy shows us that the patient is basically having a metastasis, lymphangitis basically, and he is now receiving chemotherapy for CS stomach metastasis to the lung. Now there is therapeutic IP. The interest in therapeutic IP is increasing in last 2 decades because of the number of CA lung cases rising, as well as more cases of central aortic obstruction are also coming up, and we are having the instruments and the skills to deal with them. So first, let us see how they can be. They can be mechanical obstruction of the airway, intraluminal, extraluminal or mixed. So I will show you cases of all these 3 kind of obstruction. First, Mrs. PB, 76-year-old male with known CA mid-esophagus. So when we put the bronchoscope in his trachea, it looks like that. There is a complete infiltration from the CA esophagus involving the posterior wall of the trachea, and the lumen is narrowed. Patient is having severe stridor. So what we do? We just put a guide wire, and over the guide wire, this is the guide wire that we have put, and over the guide wire we put a self-expandable metallic stent under C-arm guidance. Once the stent is in situ, you can see the obstruction is gone. The mid trachea is completely given back its lumen, and the airway is clear. So the patient can breathe very well, and the problem, it's a palliative therapy, definitely palliative therapy, but the patient is completely relieved from the breathlessness by putting this stent. So this is one of the methods of dealing with a endoluminal and extraluminal obstruction combined, when there is compression from the outside as well as a lesion in the inside. Another case, this is Mrs. AK, presented with ARDS, was on ECMO, extubated, improved, went home, but returned with this kind of a post-tracheal airway stenosis or post-intubation airway stenosis. So this is a less than 5 millimeter orifice remaining. She was having very classical stridor. What we done? We have put the patient on ECMO, and is a elective ECMO cases. After that, we have done this clearing, and when the patient was extubating, we are extubating the patient. You can actually see after the rigid bronchoscopic debulking, the airway has been again restored to its almost complete lumen. There is no obstruction. The 5 millimeter orifice has been extended to this side, and the patient is relieved of obstruction. It is almost 1 year now, and the patient is doing really good. Another case, a 74-year-old gentleman, he presented with left lung collapse, and his initial bronchoscope showing this total obstruction of the left lung. So after that, we have done a therapeutic rigid bronchoscopy, taken out the tumor, post debulking. You can see the lobes of lungs are cleared, left lung, and we can see the openings of the segmental bronchi, and it is very evident on this X-ray, pre and post procedure. The whole left upper lobe, which was completely collapsed, has been opened up. There is some areas of collapse remaining in the left lower lobe. Now another case, Mrs. MB, presented with history of fever, shortness of breath, X-ray showing mediastinal widening and tracheal compression. If you see this CT, in this CT, there was a tracheal compression with a endotracheal tissue. So when we have to take care of this case, we have 2 mottos for us. We have to diagnose as well as we have to take care of this compression. So for diagnosis, we use our much needed tool, that is a mediastinal cryopo. So we do a cryobiopsy from the lymph nodes or from the mass which was compressing on the trachea, and on the cryobiopsy we give enough tissue to diagnose this as a lymphoma. We send the tissue for frozen biopsy, and when we are sure that it's a lymphoma, then we decided to go for a stenting rather than debulking, because we know that lymphoma melt with the chemotherapy and we can take out the stent. So that happened. This is the cryo. We have put and we take a cryobiopsy, and after the cryobiopsy we just put a stent which has taken care of the whole tracheal lumen as well as the infiltrating mass. So the luminal obstruction is cleared, and the patient then received the chemo. After 3 months he has returned, and we have taken out this stent also. So she is doing well now. Another patient, Mrs. PJ, She is a 21-year-old lady, CT thorax endobronchial obstruction at right intermediate bronchus. There you can see, this is the vocal cord. As we enter the vocal cord, this is the trachea, tracheal lumen. This is the carina. On the right left main bronchus is completely free, but right intermediate bronchus is completely occluded with this endobronchial tumor. So we used all our devices like electrocautery and cryo to take out the tumor. We'll show how we'll take out the tumor. First we put a balloon beyond the lesion to stabilize the lesion as well as hold any kind of bleeding if it occurs after taking out the lesion. This is how we have inflated the balloon. This is beyond the lesion, we have crossed the lesion. This is the lesion, and then this is the electric snare what we are putting in, and with this snare we are now cutting the lesion. So we have put the snare completely.
5 minutes left.
Thank you, sir. And after that, we have put a cryo probe. This is the cryo probe. We hold the lesion and we can take out the whole tumor altogether. After replacing the tumor, you can see the balloon is in situ, which is obstructing the bleeding. And after deflating the bleeding, you can see the whole airway is clear. The remaining tissues were taken out in pieces, and this was the last impression of the airways. So she has been taken out of the tumor, and this tumor came out to be a typical carcinoid which doesn't require any further treatment, and she is basically cured. So here we come to the last case. This is a presentation and the management of acute onset hemoptysis. This is also something we are doing therapeutically. So this is a patient with acute hemoptysis. You can see this is the left one bronchus. It's a dry bronchus, no bleeding. But when we are coming to its right counterpart, there was continuous torrential bleeding occurring. We are doing continuous suctioning, but blood is coming out from this right upper lobe posterior segment. So prevent this bleeding, what you do, we put a catheter. That catheter is commonly used by gastroenterologists for sclerotherapy. You put a sclerotherapy catheter in right upper lobe bronchus and put glue, that is endobronchial glue installation within the bronchial lumen to stop the bleeding. This is a catheter coming, and we have put this catheter in right upper lobe posterior segment. Then we have stopped bleeding and we have instilled glue through this catheter. After the catheter glue is placed, you can see that bleeding has stopped. And when you come back, you can see the bleeding has stopped. We now can see into the lumen, and the blood is not coming out anymore. So this is a very easy solution for acute hemoptysis, which can be done when you are doing a bronchoscopy itself. Thank you.
Thank you, Dr. Mukherjee. Please come down to the selfie zone to receive the memento from the Senior Vice President of the Family Physician Association, Dr. Partho Sarathy Sengupta. Now, these 3 sessions, the 2 sessions which we have completed, and the session afterwards is supported by Apollo Group of Hospitals. A loud round of applause as Dr. Sengupta presents the memento to Dr. Arinder Mukherjee. Now may I request Dr. Bishambar Agarwal to call the next speaker. But before that, I have got a very small announcement. Those who have missed out on this conference ribbon, which fell short at the time of entrance, has now arrived. You may collect your conference ribbons by going to the registration desk, and you may collect them over there. The conference ribbons are sufficient in number, and they have arrived just now. Dr. Bishambar Agarwal to call the next speaker.
Yeah, now I request Dr. Devashri Chatterjee for a very illuminating session in new advancement in microsurgery.
This is a young girl, 8 years of age, and she was diagnosed to have a tumor in the fourth ventricle. So this is the tumor, and she has hydrocephalus. Basically, she came with headache and vomiting, and as happens, the moment she was diagnosed with this tumor, she was sent to NIMHANS for further treatment. This is a knee-jerk reaction in West Bengal. So they put in a shunt and they said that you come back to us after 3 months for definitive surgery. So while the child was waiting for definitive surgery, the shunt got blocked. And once the shunt got blocked, then again there is hydrocephalus, and that is a potentially lethal problem. The child can die of acute hydrocephalus. So we have taken this child up for surgery. That is how the child has landed up with us actually, because she has nowhere to go. And you can see that the posterior inferior cerebral artery is very closely related to the tumor. Now all these are microsurgical exercises, and you cannot see the tip of my fingers anywhere. So everything has been done with under the microscope. So these are not naked eye surgeries. These are not surgeries that you can do in one place in 2 hours and then go and work elsewhere. So it needs full-time involvement, and I am showing you the video of maybe only 5 minutes or 4 minutes, but this will probably have taken maybe 4 to 5 hours to do. So that is how you first have to identify the posterior inferior cerebral artery. That is very important, because you can, if you damage the pica, then patients can have devastating strokes. And this is how the tumor can be delivered. And it's very important not to disturb the floor of the fourth ventricle. This is where all the lower cranial nerve nuclei lie. So if while removing the tumor there is damage to the floor of the fourth ventricle, then patient can have lot of morbidity. That is the midline raphe, and that is CSF pulsating from the aqueduct of Sylvius. Once you've seen this, you know that you have removed the tumor in its superior inferior extent completely. This is how the brain looks after the tumor has been removed. And this is the post-op scan. Some part of tumor was left behind here because it was stuck to the pica, and probably I could not remove it because of that. This is the child after 3 months of radiotherapy. And I have seen this child last year, almost 4 years after the first surgery, still no recurrence. It was a medulloblastoma, so 5 years survival is pretty good if you are able to completely remove the tumor. So nowadays there is also a lot of emphasis being laid on natural orifice surgery or endoscopic surgery, minimally invasive surgery. These are all fashionable names for the same thing that we do. So this is a 63-year-old lady who came with progressive loss of vision in both eyes and was found to have a pituitary tumor. So this is basically how the pituitary tumor looks. There's some extension on the left side. So this we have done through the endoscope. So this is a short video of how we approach this tumor. We go through the nose. Some ENT surgeons are also doing this. Sometimes neurosurgeons combine with ENT surgeons, but I had the unique opportunity of working in INK where we learned it to do ourselves. And you can see here that we have opened up the sphenoid sinus, and we are breaking the cellular floor. And this is how you can open the dura and then go and remove the tumor. So this is just to give you a glimpse that that perhaps there are some illnesses in neurosurgery where if dissection is done well, then patients have very good outcome. So this is how the tumor can be delivered first from its posterior aspect and then from either side. And this is the post-op scan. So the tumor has been completely removed here, and the patient has gone back to completely normal life. Now this is basically to show that there are some illnesses like pituitary tumors which are usually benign tumors. So if you can remove them well, your patient has gone back to completely normal life. This is again a 24-year-old male. I don't have the recorded video of this because I happened to remove this in a medical college. So you can see that the tumor is extending from the cervix, from the C2 up to the dorsal vertebra. So almost I think 15 to 16 centimeters in length. And I have arranged the tumor. We have taken the tumor out in piecemeal fashion. This is a young man who became quadriplegic over 4 years and was bedridden for 6 months by the time they came to us. And we have removed this tumor in toto. And we thought that the patient will need post-op ventilation, but he didn't need post-op ventilation because the remaining spinal cord tumor tissue was so compressed and so compensated that with minimal damage under the microscope you can develop a plane. Obviously this is an ependymoma in the biopsy, so you can develop a plane between the spinal cord and the tumor and you can remove it completely. Obviously all this work cannot be done without having spent sufficient time in the cadaver lab. So these are some photographs from my cadaver lab days. And this is again a tumor, young man, sudden severe headache followed by altered sensorium. So 19-year-old boy was just out with his friends and suddenly became unconscious. So the father is very nervous and from one nursing home to another. One CT scan was done. As you can see, there is some hyperdense shadow here in the sella. So obviously you are suspecting two things, either an aneurysm or a pituitary tumor with apoplexy. Sodium was 115. So pituitary tumor with apoplexy has traditionally been thought to be a surgical emergency, but you need to correct the hormone levels and you need to correct the electrolytes before taking the patient up for surgery. So it's a very interesting case here because you can see that the tumor has actually occluded one of the anterior cerebral arteries here, and this patient actually had a small stroke because of that. However, he was not symptomatic, he was moving both limbs. So this is how we have removed the tumor, and this is just to show you an intraoperative complication, that this is how a CSF leak can happen because the tumor has actually ruptured the arachnoid and gone into the subarachnoid space. So when you have removed the tumor completely, the CSF can leak from that hole. But anyway, this is not much of a problem. You can take some fat and pack the sphenoid sinus and get away with it. This patient I'll skip for the sake of time, but I'll show you this patient. This is a 28-year-old lady. She had a child who was about 2 years of age, and she developed progressive suboccipital neck pain of 3 months duration and became severely ataxic. So ataxic that she could not even sit up in bed, and because she could not balance herself when she was erect, then she developed difficulty in swallowing. Food was coming out through her nose when she was trying to eat, and so a rice tube was placed. So on examination she had weak gag reflex and the trapezius was weak, and you can see here that there is a lesion in the right in the cervicomedullary junction. So obviously when you see a scan like this, only two things come in mind: either it's a hemangioblastoma cystic or a pilocytic astrocytoma, and both are benign tumors. So if you can remove them completely, your patient can go back to completely normal life. So the stakes become very high. If it's a malignant tumor, maybe you can say that okay, the disease was bad and there is a complication, but when the tumor you are suspecting that it's probably a benign illness, then it becomes a challenge to do it well. So this is how we have done. We have done a craniotomy. This is the cranial end of the patient. It's a caudal end, and you mark the cervical vertebra here, the C1. That's where the vertebral artery goes inside. With navigation, you localize the lesion, and then you open up the dura, and you can see how bright red the tumor looks. That's CSF coming out after opening the dura, and the tumor is small here, maybe about just a centimeter, but the location is very difficult because it's sitting right on the upper end of the spinal cord. So if there's too much of bleeding or if there is a problem at the time of dissection, then the patient can have devastating complications. So these are feeders from the posterior inferior cerebral artery which is supplying the tumor, and they have to be removed just like an AVM. So once you see this, you've already got a diagnosis. This is probably a hemangioblastoma. So you isolate the feeders very slowly, and don't get into the tumor right away, because in some tumors you can get inside the tumor and remove them, but if you get inside the tumor like this, it bleeds like this. So they have to be done very in a very delicate manner with gentle dissection, and this is how you can dissect the tumor from the spinal cord. So these are dissectors which are hardly 1 millimeter into 2 millimeter in size, very small and very sharp dissectors. So the tumor shares the pia of the spinal cord. So you can dissect the tumor from the pia of the spinal cord in this fashion. And interestingly, you can see that there are some blood vessels which come from the spinal cord.
Left.
Yeah, you can which come from the spinal cord up to the tumor, and they are common. So the spinal cord is also taking blood supply from those vessels, and the tumor is also taking blood supply from those vessels. So you cannot coagulate blindly. You have to see the vessel which is going into the tumor and then dissect it. So for the sake of time, I'll just fast forward it. You can see this is the 11th cranial nerve which has been dissected off the tumor. And as you have devasculated the tumor starts to become blue in color. And this is how you can deliver it. That's the cystic part coming out. So this is done in an intraoperative neurophysiological monitoring because you have to know if you have caused any damage. And if you see here that at this point here, this is the normal side. There is no signal on the abnormal side, which was the left side. And see, the signals have started appearing as soon as you have removed the tumor, and the signal on this side has gone up. So the histopathology was a hemangioblastoma, grade 1 tumor. We have removed it completely. We saw this patient, this is C in the ward before she could be decannulated, and this is at 2 months. So young lady who could not sit up, who had a rice tube in her mouth, through her nose, has gone back to completely normal life. For the sake of time, I'll not share this. But I want to share this picture. This is one of my very close friends, Dr. Nishad from Azerbaijan, who I spent a significant time during my fellowship learning how to work with cadavers. He was 5 years younger to me, but taught me how to work in the lab. And he used to use Google Translate to speak in English because he couldn't speak English well. And this is how he said, working in the lab is not time wasted, it is time earned. I'm sure he used Google Translate to say this. These are some pictures from my fellowship, my mentor, Professor Bashkaya. And I never finished my presentation without this slide because I was very lucky and fortunate to have been taken under wings of some giants of neurosurgery, one of whom is actually here with us today, very early on in my career. And they have molded me in many ways. So what is my hope? I think it remains same, slightly utopian, that we are able to provide good microneurosurgical services to the people of this region of the country without any discrimination of whether they can pay or not. That is my utopian hope. Thank you.
Thank you, Dr. Chatterjee. Please come over to the selfie zone to receive your memento from the Honorary Dynamic Secretary of the Family Physician Association, Dr. Sukumar Das. Now, these last 3 sessions were supported by Apollo Hospitals, Kolkata, and we are very grateful to them. The next upcoming 2 sessions will be supported by the Institute of Neurosciences, Kolkata, and we have got Dr. Rishikesh Kumar, Senior Vice President of the Institute of Neurosciences, to proceed with the 2 sessions after the memento presentation is over. Dr. Devashri Chatterjee, please come over to the selfie zone. A big round of applause for Dr. Chatterjee as Dr. Sukumar Das, Dynamic Secretary of the FPA and the Dynamic Secretary of the FPACON 2026 is handing over the memento to Dr. Chatterjee. May I request Dr. Kumar to call the first speaker on behalf of Institute of Neurosciences, Kolkata.
Thank you, family practitioner. May I request Dr. Pratim Chatterjee. He is my colleague and a stroke neurologist at INK. Very dynamic person, and he is well trained in intervention neurology also. Pratim will speak on time is brain may not be enough, and will break the myths and barriers in the stroke. Pratim, all yours.
Thank you, sir, for the kind introduction, and thank you to the Family Physician Association for giving us the opportunity. So my topic is a bit different than what we usually say about stroke, and the whole 20 minutes will be to have a newer update or some newer view of how we think every year newly about stroke. We have been very persistent, and rightly so, that time is the most crucial factor in deciding how to tackle a stroke, what to do, and what will be the prognosis and the outcome. But with time, again, things have changed, and I believe this update will help us know the latest evidence and our practice at INK, what we are practicing and how we are molding our stroke care pathway with respect to not only time but to many other things. So let's go ahead. So we all are accustomed with the slide that what a stroke is, and when we talk about stroke we must not restrict ourselves to the ischemic pathology, but as you can see it is almost, as per epidemiological data, 87% of the stroke in this part of the country. So ischemic stroke, and most importantly something which is time dependent, this is the most important stroke which needs to be talked about in this conference. So basically what happens in ischemic stroke is, keep it very simple, any of the blood pipes get clogged. That's what it happens, and the brain starts rotting. So we are also accustomed with the fact, very clearly displayed in various propaganda boards across the city, that 1 in 4 out of the population will be affected with a stroke, and it is probably the biggest epidemic we are encountering in the recent times, with almost a huge amount of pandemic in the coming years. But the more important fact is something else. The important thing is, it is not only an increasing epidemic, but the mortality rate, and specifically the data from the last epidemiological study across the country, shows that Kolkata unfortunately has the highest case fatality rate, almost accounting to 42.1%, which is the largest in the country for a stroke patient. And you can see the increasing burden in West Bengal, and more so increase in the young. This is the data since 2021, and I believe that the COVID pandemic could play a big role in this, apart from our change in the lifestyle and the sedentary habits. Concern is really the death rate, and you can see West Bengal is really very dark in this, and as I said, highest fatality rate is Kolkata. So very, very right time for us to keep our sleeves off and get aware and updated about how we can save these patients. So basically, when we talk about tissue window, or when we talk about what are the updates, we restrict ourselves talking about penumbra. Penumbra is an old concept, basically the brain which is lost is the core, and the brain which you can save is the penumbra. Now this is all what we knew till date. We knew that this is a race against time. We say, oh, I'm so sorry the patient came late. That's why probably going with the conservative management will be good for this patient, and we can't unfortunately do much for this patient. But these are all old concepts. We'll see how it has evolved. So, initially the data and the evidence showed 3 hours as the critical time window. It's increased till 4.5 hours, which we have been calling as the golden period. But what if I say to you that today it has increased till 24 hours, and not also 24 hours, today is increased beyond. But having said that, I clearly clarify myself that every second counts, that it is not equal for all patients, and that for your patient also, you must remember the fact that it is not even 3 hours. Remember, every second is important. Wasting a second, wasting for that golden time to disappear, is in fact a criminal negligence. So we must not wait even a second, but we must also know and appreciate the fact that the patient beyond 4.5 hours doesn't disqualify himself or herself from the rightful treatment to get back to the functional life of after acute stroke management. So why penumbra matters is because brain stroke outcomes depends on that, and penumbra lost is brain lost. One brain lost is one family lost, one functionality lost. So penumbra saved is you save a family, a person, a functionality. We all are accustomed with the spotting signs of stroke, and I will not waste much time in a physician conference with this. And it's important we also know that when to call and call the emergency. But here is what I emphasize upon, that redefining stroke management, paradigm shift in the thinking and the grading of stroke patients, and selecting the patients for the rightful treatment and the translation to practice. So since 1996, when the NIMS trial evolved, till 2025, you will be amazed to see the development of the evidence so far. And 2025 is the time of the HOPE trial, which says that 24 hours, till 24 hours, even patients of thrombolysis are showing some good impact at times with selected patients. But these are selected not in all patients. These are for selected patients, we'll define them. But what are the myths? The myths are beyond 6 hours from symptom onset, all the salvageable brain tissue is lost, reperfusion is futile or even dangerous. However, the fact is something else. It all depends on few things. The most important is the collateral grading, the collateral circulation. How much the brain or the body is trying to save the amount of the brain lost. That depends on the collateral. So it varies from individual to individual. You just cannot label him based on a time slot, that you are out of 4.5 hours, you do not qualify, so you are out of window, we should not give you all the acute management protocols. No. The evidences are very, very beautifully in our favor. So the DAWN, the diffuse 3, the extend, the HOPE trial extends the window from that scanty 3 hours till 24 hours now, not only for thrombectomy or endovascular, but also probably for tenecteplase or for thrombolysis. So the time is changed to the tissue. So there is, from the time clock which we have been emphasizing so far, we move now to the tissue-based clock. So all these obviously depends on the collateral grading, the core growth, the growth rate of the stroke for that patient, and which indirectly determines the salvageable penumbra or the ischemic penumbra. It varies from individual to individual. Now, how to know basically that this patient is a rapid progressor or this patient is a slow progressor? How to decide that you can still open an artery after 36 hours and give this patient a benefit to the cost? So basically, the collateral circulation gives a very, very important, idea. So obviously, we will talk about CT perfusion, we will talk about perfusion studies, but not all every labs, not all every hospitals will have these advanced imaging facilities. However, with a CT angio, you can do a collateral grading, and you can, as shown by the evidence, you can basically predict the outcome that patient will have after the stroke management. So, of course, the CT perfusion, the MRI DWI flare mismatch have been helping us till now for this advanced time window protocol. So beyond 4.5 hours, it is a dictum to have this advanced imaging to actually have an evidence of the amount of salvageable brain tissue we will be saving to justify our management. So as I said, that the studies and the level is, you can see the level is 1A, that 4.5 hours to 9 hours for thrombolysis, and you can see it is significant improvement. The adjusted odds ratio is almost 1.44 with almost a 35.4% patient benefit over the placebo in patients with extended time window. Now also for the wake up, so the patient coming out just after the sleep with a stroke, we take the last will seen. So there are wake up trial, there are Mr. Witness trials, which clearly takes help of the MRI DWI flare mismatch, and we can now, with the help of this imaging protocol, also thrombolize these patient groups. The HOPE trial, as I have said, all are in positive evidence, though obviously with a slightly increased rate of symptomatic bleed have given increased benefit outcome, therapeutic benefit till 24 hours of stroke onset. So a huge shift, paradigm shift in the thinking of the golden window. Now the safety profile, comparably safe across 9 hours, increased risk of bleed obviously beyond that, but that also in select patients. Net clinical benefit outweighs the hemorrhagic risk, and that is a very, very important statement I want to make it out here. Obviously, nothing to talk about the early window. So within 6 hours, absolutely within guideline to go for endovascular thrombectomy for large vessel occlusion, but for 6 to 24 hours, we are well aware that we have very good evidence for DAWN and for diffuse trials that we can take select patients. But what if they do not fall in those criteria? What you have already a formed infarct and you have a large vessel occlusion, and then the patient comes to you around say 12 hours. Will you exclude those? No. The evidences are still in our favor. We are talking about this because we are in an era where we have to justify our actions medico-legally. So the evidences even say that within 24 hours, beyond the DAWN and the diffuse criteria, these patients do have fair amount of therapeutic benefit. So you are rightly justified in giving select patients an option of reperfusion. Even large core ischemia, those patients who have almost blackened, poor aspects, they are showing better benefit compared to normal. Posterior circulation, absolutely separate dynamics compared to the anterior circulation, and the extended window. We have even done till 72 hours in some patients of posterior circulation with fair amount of benefit, but all that depends on, again, the amount of the tissue lost and the amount of the tissue which can be salvaged. So clear cut, the guidelines are bridging protocol, holistic prognostication and advanced imaging, perfusion-based studies, collateral grading in case beyond the normal window. And IV thrombolysis we have already discussed in the extended window. The AI automation tool like what we use, Rapid AI protocol and various other AI protocols we use in our Institute of INK do help us in odd hours of the day and night for a very quick assessment that this patient will require a reperfusion and will do well with a thrombectomy or with a thrombolysis. So there are some myths, the clock myth, the CTP myth, the access barrier, the safety fears, and I have clarified them with evidence that we have moved from the time to the tissue-based window now, and this is the reality. There are also some myths. Age is more. Should we at all give an attempt? it is a small stroke. Is it right to bring to the hospital? Because we have seen nothing helps. Go for alternative medications. You will see huge amount of patients of stroke going for alternative medications in alternative form of therapy in periphery specifically. We brought to the hospital, yet the patient was lost. My relative had stroke, she recovered by herself. Now these are all myths. Why? Because with evidence, we have seen that stroke is not equal for all. A small stroke now may be a harbinger of a bigger stroke just some time later, and it may be a stuttering stroke. So understanding the pathophysiology, going to the stroke hospital, going to a stroke prime center makes a huge amount of difference to the outcome. But having said that, I will just, for the sake of time, I will just skip my slides a bit. So having said that, you must understand that not all cases are same. Like for this patient we did just 3 days prior, a 78-year-old, so that myth of old age, 18 hours, tandem occlusion. So one clot you can see right at the ICA. So first image is right at the ICA origin, so at the neck, and then again a distal clot in the MCA. So tandem occlusion, 2 places occlusion. We just went in, 18 hours, good amount of salvageable brain tissue, good collateral outcome. So just you can see with 2 passes achieved the TK3, and this is the patient taken of course with consent. This is the patient at home, and these are the huge amount of clots, a cardioembolic shower which happened, and because of his collaterals perhaps we had a very good result even at 18 hours. We had now been doing innumerable such cases at INK beyond the time window, and stretching our limits, of course taking care of the fact of the safety and of decreasing the hemorrhagic risk. And you can see patients going back and posting their videos while functionality assessment at home. But not always all cases are good. Some cases are bad. And here again comes the factor of honesty and transparency. Standing in a scientific forum, if I say that if I do anything, I do always well, and we do not land in complications, I am 100% wrong. But we must accept the fact. Today, if a large AMI patient crashes, probably his physician will never, and relatives also will accept the fact, okay, this can happen. But how commonly we accept the fact that even after giving the best of effort, the hospital did thrombectomy, did everything, but we could not save a large vessel occlusion patient. Probably the thinking might be otherwise, though it was probably not necessary, the patient would not have survived. I beg to differ that we must give every such patient a chance to live, but we are not always 100% successful as in all other surgeries. But yes, majority of the cases, if properly selected, do give a very, very good results as I have shown. So consistency is the key, dedication and honesty are weapons, success not guaranteed, but to not try is to not even start. So the key takeaways is tissue-based decision, evidence is in our favor now, and we must build our systems, and that includes creating the right symphony, creating the right orchestra, having the right people in, having the right leadership, as with our we have rightly developed in our system. We are proud to have a very prompt cath lab team, a stroke team, and a separate dedicated stroke unit which takes care of the stroke patients, because not only the intervention in the acute phase but also the rehab which starts simultaneously. Yeah, I'm done almost, last slide. And most importantly, the other parts of the stroke management, whatever I have shown to you is perhaps only 10 or 20% of stroke management. The actual outcome comes beyond that, and that is where I really stand so happy and proud that my institute offers the full range of rehab care just at the time of the patient entry along with the acute care. And so this is a dedicated stroke unit which takes care of the ups and downs of the daily and the follow-up monitoring of these patients. And this is my institute. Thank you so much.
Thank you, Dr. Chatterjee. Please come down over here to the selfie zone to receive your memento from Dr. Biddu Rai, who is the past secretary of the Family Physician Association, Kolkata. May I request Dr. Rai to come over to the selfie zone, and a warm round of applause from the audience as Dr. Apratim Chatterjee receives his memento from Dr. Biddu Rai, ex-secretary of the FPACON and the secretary of the ex-secretary of the Family Physician Association. Wide round of applause, loud round of applause, please. We are proceeding to the last session before lunch, and I shall request Dr. Kumar, who is the Vice President of the Institute of Neurosciences, to call the speaker onto the dais for the last pre-lunch session.
Thank you, sir. Thank you much. May I request Dr. Preetham Majumdar? He is my another colleague, young dynamic neurologist. He is trained in demyelination and inflammatory neurology. He will speak on young brains, long battles. Preetham, all yours.
Hello, good afternoon everyone. I am Dr. Preetham Majumdar and I am a consultant neurologist and a neuroimmunologist at the Institute of Neuroscience, Kolkata. So I am very privileged and honored to talk to you about what is the need of the time. So this particular spectrum of neurological disorders we're talking right now.
Let me share with you that from the morning, one very senior lady member of Family Physician Association, although she is in this post, she has been handling all the memento presentation and the give this memento presentation and honoring of the guests herself alone. Dr. Pamela Ghosh deserves a loud round of applause. In spite of her in this position, she is doing a lot for the Family Physician Association. Please applaud her. After this session, we will have the inauguration session. It is a very glittering inauguration session. May I announce the names? We have the chief guest, Professor Sukumar Mukherjee, who doesn't need an introduction to any doctor in Kolkata. We have the guest of honor. We have the inaugurator amongst us already. He is present amongst us. He is the founder, father of the Institute of Neurosciences, Kolkata, Dr. R. P. Sengupta, who has passed almost 64 years of his life working outside India in Great Britain. And our guest of honor, Dr. Raja Dhar, has also arrived amongst us. He survived a near fatal accident a few months back and has come back strongly more than before to be amongst us. So we wish him all the best and wish him good health for the rest of his life. Stay back for the inauguration session after this session.
So good afternoon everyone. I am Dr. Preetham Majumdar and I am a consultant neurologist and a neuroimmunologist at the Institute of Neuroscience, Kolkata. And I am really honored and privileged to talk to you about a very interesting spectrum of neurological disorders. This spectrum of neurological disorders affect the young brains. They will lead them and they will fight them with a long, prolonged battles, continuous long battles, and ultimately will leave them crippled and wheelchair bound. The good thing about these disorders are they are very preventable. So what are this type of disorders? These are central demyelinating disorders, and we'll also learn what are the emerging therapies. So our talk will go through why we'll spend time, why we're talking on this. We will know about the clinical presentation of this type of disorders. We will see what is the spectrum it fits into, and then at last we'll see the therapies. So let's begin with a case. Now she is a 31-year-old lady, very young. She had a history of right optic neuritis, that is right optic nerve was inflamed in 2016 and was not treated, because of which she was visually blind. Only projection of light was positive. She came to us in 2024 with the similar symptoms in the left eye. That is a painful left eye vision loss, just similar to the right eye. Now this time, when we did the MRI, you can see that the left optic nerve is inflamed, while the right optic nerve is atrophied, that is the old insult. Now this optic nerve is also having diffusion restriction, and this is also having contrast enhancement, all pointing towards an active optic neuritis. So what we gave her is the standard of care, methylprednisolone high dose. She turned out to be NMO strongly positive. These are a type of demyelinating disorders. We'll talk in detail afterwards. Her course was very interesting. So on the day 2 of the illness, she had no improvement in her vision. Day 3 was even worse. She even dipped, more vision loss. But we continued the IV steroids. Day 4, the vision dipped further. Now imagine this female, already the right eye has already gone and the left eye is still on the same position. So she was pleading to us, please save us the eye. What we did is we became very active. We gave her rituximab, one of the monoclonal antibodies which works best. We continued the IV steroids and we gave her a very good therapy called as plasmapheresis, 5 cycles. As a result of which the left eye vision came back to normal. But the right eye vision was permanently impaired. So what does this tell you? That if we treat them at a right time with a right therapy, they will have no disability. But if you miss that, they will have some permanent disability left. So that's why our dictum in autoimmune neurology is hit them the earliest and the hardest way possible. So what are demyelinating disorders? Let me tell you a very interesting story. So there is a hospital in Paris in 18th century known as Salpêtrière. And we have a very interesting and a very good neurologist and a physician there known as Jean-Marie Charcot. He was so famous at that point of time, he used to have 2 classes. First on Tuesday, one on Friday. And one from around the world used to attend that conference. Now, he was a very keen observer. So what he observed that time Parkinson's was known as the shaking palsy. And as we all know, what happens in Parkinsonism is you become very slow, you become stooped, but one of the most characteristic features are the rest tremors, not the action noise, right? So what her maid was very young. She was not slow, but she had tremors which were more on action, not on rest. So that means she was completely different. Now, her maid became so crippled that ultimately she died after 10 years. And he was so smart enough to do the biopsy. And what he saw in the biopsy, you can easily see these pink spots in the brain. They are the active demyelination spots. And he did the biopsy as well. And you can see the pink things on the myelin. These are the destroyed myelin. So that he termed as la sclerose and plaques, and what we know as demyelination. So in simple words, what in today's language demyelination means is you have a neuron and you have a covering around it that is called the myelin, and that myelin is damaged. And what it looks like in MRI is the white spots in T2 flare. You can see the white spot here, that are the active demyelinating lesions. So the confusing thing about demyelination is its presentation. It has a myriad of presentations, so confusing. So let's decode them. The first presentation, which is most common, is optic neuritis. Now you can see in this picture, there is a female who is dropping her eyes. That tells you what optic neuritis is. They affect the young to middle age. They will have progressive vision loss with eye pain. And on examination, we do a thing called relative afferent pupillary defect. We will see in the next video what is RAPD. And if RAPD is there, it is more suggestive of optic neuritis. We also check the visually evoked potential, which we measure the latencies of the optic nerve. Of course, if the optic nerve is inflamed, the latencies will be high. The fourth thing what we do here in INK is the optical coherence tomography. Here we measure the optic nerve thickness. And of course, in optic neuritis, the thickness will go down. Now, what is RAPD? You can see in this video. So what happens when you flash a light on your eye? The other eye also gets contracted, right? So this is called the consensual eye reflex. But look, so now, what will happen if the left optic nerve is involved? Look, the torch is being shined on the left optic nerve, nothing is happening. So that is called as the swinging flashlight test, which we say for optic neuritis. If it is positive, then it is more predictive of optic neuritis. In the MRI brain, you can see that the left optic nerve marked over here is T2 hyperintense and is having a contrast enhancement. That also tells you that there is active optic neuritis. The second and most common presentation is myelitis. So if you have a patient presenting to you with either a paraparesis, quadriparesis, but you have a definite sensory level and the bladder, that is spinal cord, nothing else. So on examination, we'll have sensory level, increased reflexes, and plantars will turn down extensor. Now in this MRI spine, you can easily make out there is a white lesion in the cervical spinal cord, and on the axial also you are seeing the same. So that is active myelitis. The third thing and very common is brainstem, and all we know is brainstem is very complex. It has multiple fibers passing through it. So any lesion around that will cause multiple symptoms. And the first symptom is diplopia or oxylopsia. Oxylopsia is trembling of vision. So patient will tell you the vision is trembling. And what will happen is in the midbrain, you can see this structure. This is the medial longitudinal fasciculus or the third nerve nucleus. So if you have a demyelinating lesion over here, you will have diplopia. The second presentation of brainstem is a quadriparesis or a hemiparesis, mainly crossed. Why it happens? In the brainstem, you have this structure called as transverse pontine fibers or a corticopontine fibers. If you have a lesion over here, you will have a crossed hemi or a quadriparesis. Another most common presentation is the ataxia. Patient will come to you, I'm not able to walk in a straight line, imbalance. Why it happens? Because here only we have pontocerebellar fibers. If you have a lesion here, the patient will present to you with ataxia. Now diencephalic syndrome, very interesting. I also didn't know about it previously, but this is one of the manifestations of demyelination. So diencephalon means hypothalamus and thalamus. If you clearly recognize thalamus is here, and what it will give rise to is polydipsia, that is because hypothalamus takes care of the hormones, so antidiuretic hormone will be increased. The patient will present to you with polydipsia, hypersomnia, and narcolepsy. This is also a common presentation of demyelinating disorders. The fourth is the cerebrum, that is the white matters of the brain. So if you have a lesion here, you can present with hemiparesis, hemisensory loss, and a callosal apraxia. The fifth and a very important and unique thing is area postrema. So in the brainstem, this is the medulla, right? And the dorsal surface of the medulla, we have a zone called chemoreceptor trigger zone. Now this is the vomiting center. So if you have any lesion over there, patient will present with recurrent hiccups and vomiting. Just imagine for a time that if the patient presents you with hiccups and vomiting, the first thing you will send to is gastro. But the thing is, it is neurological. So we have to make a differentiation here. The next thing is cortical encephalitis. Any patient presenting with you fever, meningismus, headache, seizures, you always think about meningitis. But what if I tell you there is a thing called MOG, myelin oligodendrocyte protein, and it will present similarly as a meningoencephalitis. So all this are presentation of demyelination. And how do we classify demyelination? We have primary demyelinating disorders, which means nothing else in your body is wrong. It's only demyelination. And we have three disorders over here. Multiple sclerosis, which is the most common one. Neuromyelitis optica, most common in Asians and Indians. And the third one is myelin oligodendrocyte glycoprotein. While the secondary demyelinating disorders tells you that there is something wrong in your body, and the demyelination is the secondary thing. What we have is the connective tissue disorders, we have vasculitic disorders, and we have granulomatous disorders. So the three buckets of primary demyelination we'll talk about today are the multiple sclerosis, the neuromyelitis optica, and MOG spectrum disorders. Now let's go into detail. Demography. MS patients, more will be females, but look at NMO. More and more females. So NMO is 9:1, MS is 3:1, but MOG is male is equal to females. Now if we tell about the course, MS is either progressive or a relapsing. What do we mean by that? If you see in this particular diagram, these pink lines are the relapses, acute attacks of things. And this line in the blue is called progression line. That means slowly accumulation of disability. So in MS, you have relapses as well as progressive disability. What happens in NMO? NMO is a very disabling disorder, but it doesn't progress without relapses. So first thing is relapses, relapses, and relapses. That will only make you worse. While the third thing is MOG. MOG is very relapsing, but it is very good because it has minimal or mild disability. Can you see that? So if I go into the recovery part, MS is yes, has a recovery. NMO has a poor recovery, while the MOG are the best ones, have a good recovery, but they are relapsing. Now if I go into the biomarkers, now for a long time MS is known as not an antibody mediated disease. It has no antibody, and correctly so. But what we find in CSF is OCBs and kappa-free light chains. But in NMO, in the blood, you will find aquaporin 4 antibodies, you will find MOG antibodies. The emerging antibodies which are apart from this primary demyelination are the GFAP, glial fibrillary acid protein, and what it is a primary of vasculitis. You can see here in this type of MRI, there is a perilinear radial enhancement going from the ventricles. These are all the vessels which are being enhanced. Ultimately, it will be seen as demyelination, but it's primary vasculitis, GFAP. Now, why they should be identified very early? Very important question. Now, here in this study, they have compared MS patients who were treated within 2 years and after 2 years. And see the remarkable difference. The red ones are treated after 2 years. Disability happened within 3 years of the onset. But see the second group. Disability happened after 10 years. So we are able to buy 7 years of time from the most severe patient if we treat them early and with a very good therapy. In the NMOSD also, you can see that CR is complete remission. So if we begin plasmapheresis within 2 days, the complete remission, you can see the gray line, is markedly huge, isn't it? So that also tells you that in NMOSD also, if we start Plex very early as a first line, you can cure most of the disability. Now, what are the therapies in demyelinating disorders? Now, I divide them into two. The first is the acute treatment. We have high-dose corticosteroids over here. We have intravenous immunoglobulin. But what I will vouch for today is plasmapheresis. The next one is the maintenance treatment. Maintenance treatment, we have oral therapies like azathioprine or MMF. We have monoclonal antibodies like rituximab. We'll talk in detail about this. So let's talk about the acute treatment, and what I want to talk about is plasmapheresis. Now, what is plasmapheresis? So let's understand antibody in detail. So NMO, all the antibodies are in blood. So what you do is, you give first line IV steroids and rituximab. What IVMPS does, the high dose corticosteroids does is, cools down the acute inflammation. It decreases cytokines, it decreases macrophage recruitment, it suppresses the B and T cell recruitment. But most importantly, what an IV pulse does, which oral can't do ever, is the effect on the genomic pathway. So the genes of anti-inflammatory thing will increase and the pro-inflammatory will decrease. What rituximab does is it inhibits the formation of new antibodies. But just see, the last man standing is the antibodies which are already formed by the disease process. And how to take care of that? Nobody is taking care of that. And what we can do is wipe them out. How to do that? We will take out the bad plasma out from the patient and we will suppress with the fresh plasma. So this is known as plasmapheresis. Now the most important step in plasma is to separate the blood out of plasma. And we have two different therapies for it. Apheresis, that means we will take advantage of the molecular weight and separate the plasma out. And the second is filtration. We can just filter it like a tea and take the plasma out. But what is more important is, you can see over here, the comparison. So in the centrifugal apheresis, the efficiency is 90 to 95%, while the typical duration is only 1.5 to 2 hours. So that means in a less time, we can do marvelous job. And that's how INK is going in front. We are taking the apheresis machine, we're starting it more sooner. Now, last but not the least slide, the pathological processing. So, if I bring back to the old immunology days, when antigen presents to the antigen presenting cell, we have CD4 T cells which are stimulated. Here we have a genetic component, and the CD4 T cells will stimulate the B cells. This B cells will lead to the NMO antibody, and this will be formed in thymus. This NMO antibody is restricted by the blood-brain barrier. What improves is the IL-6. It makes the antibody pass through the blood-brain barrier, and it's ultimately in the brain, and it damages by 3 mechanisms. The first is receptor internalization, that means all the receptors will be internalized. Second is complement-mediated damage. We all know complement is a very harmful thing, it will lyse everything. And third thing is the antibody-dependent cleaving, the natural killer cells, which are the self-bomber cells. So ultimately it will lead to destruction of the astrocytes, oligodendrocytes, and demyelination. What we have therapy over here is the CD4 plus T cells can be taken care with the help of this type of therapy. B cell can be taken care with the help of rituximab, CAR T cells, and bortezomib. IL-6 we have tocilizumab and cetuximab. Complement we have eculizumab and ravulizumab. Whatever I have marked in green, we have in INK, and we are regularly doing that. So I will end my talk with a very interesting story. Now, he is Sir Augustus Frederick. He is the first cousin of Queen Elizabeth. What he went through is, he was the first diagnosed case of MS. In 1822, when he was 28 years of age, He had an episode of optic neuritis. See it, 1843, 49 years. Just after 20 years, he is wheelchair bound and crippled. What makes it very interesting, he had a very good diary according to him. And what he writes down is very interesting. He writes down that he's able to walk now only in his room for 65 minutes, then it fall down to 34 minutes, and ultimately 6 minutes. No treatment was available that time. So the conclusion is recognize these things early, treat them early, and monitor meticulously. So another thing is we have Gamma Knife, an amazing treatment for brain tumors available in INK. INK is the only hospital in the Eastern India to get this. No need to travel far away anymore, we have it here. Other brain tumors, other than brain tumors, we have AVM, trigeminal neuralgia, psychiatric disorders, and epileptic disorders also being taken care. Also, the treatment is completed in 1 day. No need to visit for 30 to 35 sessions. And I will end my talk with the famous saying of the Atul Gawande. He is a famous surgeon in US. He tells that above all, it takes a willingness to try. Not all things will go into good results, but we should try. So thanks for patient listening.
Thank you, Dr. Majumdar. Please come down for the customary memento presentation to be distributed by